Hi, I'm Alexey Danilov, professor of hematology at City of Hope, and I'm a CLL physician scientist. And with me here today is Dr. Brian Koffman, who I will ask to introduce himself.
Hi, I'm Dr. Brian Koffman. I'm a retired family doctor and a CLL patient myself, and I'm the co-founder, executive vice president, and chief medical officer in the nonprofit CLL Society.
Dr. Koffman, you shared some exciting data at most current annual ASH meeting, abstract which focused on understanding patient preferences for CLL treatments. Can you tell us briefly about what you have found?
Sure. So there was a major paradigm shift in the last decade of how CLL is treated. And now we have treatment options that are not chemoimmunotherapy, but rather targeted therapies. And this research looked at how patients made decisions and what was most important for them in terms of those decisions. It used what's called a discrete choice experiment. And this is a very particular way to do a survey, to do research. And what it does is essentially set up two different desirable outcomes for patients, or potentially desirable outcomes for patients, and have them decide and rank which is the most important to them. And there was 7 of these, and I'm going to read those to you. There were 7 attributes with varying levels. The chance of achieving progression-free survival at 2 years, treatment results confirmed with measurable residual disease or MRD testing or routine testing, the frequency of administration, the duration of treatment, the risk of tumor lysis syndrome, the risk of atrial fibrillation, and the risk of fatigue. CLL Society was involved in recruiting the patients, and this occurred between April and June of 2022. There were 229 patients involved, all from the US, with a diagnosis of CLL for at least 3 months. The mean age was 66. Now, we know the average age of a CLL patient tends to be older than that, but in surveys, we also often see younger patients answering the survey. We also saw that there was a larger number of females, which were approximately 2/3 of the patients, where females usually represent a much lower percentage, but females tend to fill out the surveys more. And over 95% of the patients were white. Patients, I'm going to correct that. 59% of the patients were females, and 2/3 of the patients reported having had treatment for CLL. And of those 2/3 that did, 7 out of 10 were still on their therapy. So we are. You want me to go over the results now with that?
I can ask you a question with that.
Sure.
And Dr. Koffman, so what were the key results of this study?
So the key results of the study was the most important thing to patients when they had a choice to rank things was the ability of a therapy to improve progression-free survival from 70% up to 90% confirmed with MRD testing. That was the most preferable outcome for patients. It far outranked everything else. Patients preferred taking a pill over IV infusions. They preferred a fixed duration over continuous therapy until progression. It was somewhat important, but only to a few patients, to reduce the risk of tumor lysis, reducing the risk of atrial fibrillation from 10% to 0%, reducing the risk of fatigue 35 to 0%. Those were the other outcomes. But by far the most important, and we were very happy to see this, was that what was most important to patient was is my cancer going to stay controlled? How long am I going to get this what are my chances of this progression-free survival, and can it be confirmed with MRD testing?
Well, that's very interesting. And so, Dr. Koffman, my understanding is the way the survey was administered is an invitation was sent, right? And then CLL patients had an opportunity to respond. So do you think these findings are representative of the whole patient population at large? I'm certainly intrigued by your finding that MRD results are so important to patients.
That's a great question, and what you're really getting at is there an underlying bias, and there always is. The patients that fill out these surveys, which admittedly takes some time, are the ones that are interested in their care, and those are the same patients that are reading the CLL Society's weekly newsletters, are visiting our website, and are reading the research that you and other people put out about minimal or measurable residual disease, looking at studies that are and getting excited about progression-free survival, overall survival, which wasn't one of the discrete choices in this survey. So those patients see those terms, know what they mean, see why abstracts presented at ASH and published in the important medical journals all focus on these areas. So it's a more aware, more involved group of patients than perhaps the average patient, who might be more moved by, oh, it's so much easier to take a pill than an IV therapy. That might be important to them. It's better to take something that's a limited duration versus something that's I'm going to be taking until I progress. Not that those weren't ranked as important to patients, but they were much less important.
Yeah, that's very interesting, and it does correlate with the finding the importance of MRD and detectable MRD. It correlates well with the finding that patients are more interested in fixed duration therapies. But on the other hand, you also find that patients are more interested in taking an oral treatment at home rather than coming in for monthly infusions. And of course, the currently approved treatment, fixed duration treatment for patients with CLL, is a combination of venetoclax and anti-CD20 antibody, which is an intravenous injection, or I guess could potentially be sub-Q, but still involves coming to the clinic. So do you think this will then pave the way for novel doublets, which is, say, ibrutinib and venetoclax, which are administered for a year and a half, and both of them are oral? Do you think this is what patients will like then?
Well, I think that the future for a completely oral therapy that is of a limited duration is going to be very appealing to patients, because these therapies are contingent, at least in some designs, on not only having a limited duration, but having that duration determined by the amount of disease, and getting to undetectable measurable residual disease, at least in some trial designs, is the determinant of when you can stop therapy. So plus, there is good evidence, at least with some therapies, in fact, with almost all therapies, that the depth of the remission is directly related. In fact, it's a surrogate for the progression-free survival. So if we can get patients to undetectable measurable residual disease, and patients are aware of this, this is an early sign that these patients are very likely to have very durable remissions. And there are many data that support this with all different combinations. So if you have that picture, a limited duration, all oral, getting to undetectable measurable disease, which should translate into long progression-free survival, this is an ideal therapy from a patient's perspective.
Yeah, that's certainly a very provocative discussion. As you know, this oral combination treatments have already been approved in Europe, but not in the United States. So maybe research like this is important to help regulatory authorities decide what treatments should be introduced into our everyday practice. So hoping to hear more on this, and maybe a larger sample size, maybe incorporation some of this oral doublet questions in the future. So what type of the future, sorry, what do you anticipate as next steps for this research?
Well, I think there are two parts to this I want to go back to. I think first, I want to go back to your point that I think this research makes a difference, and and although a patient's preference shouldn't be the only factor, and we have to look at safety and efficacy, I think the input of patients should be involved in all steps in drug development and in drug authorizations. And that can't be just a token involvement, check a box, but patients should be involved in discussions about what therapies are going to go forward, and their input should be involved when decisions are being made about authorizing these kinds of therapies. And regretfully, this isn't always done to the fullest extent that's possible, because I think there are some very sophisticated patients who could make an important impact on that. In terms of where this is going, I think that it's going to be important to look at not how well patients feel about their therapy, how enthusiastic they are. This may, and probably does, and past studies in other diseases have shown, relates to how well they comply with the therapy. And this will probably relate to better outcomes. I think this is a whole area of research that needs to be looked at. When patients are excited about their therapies, of course, that's not enough. We need an efficacious and safe therapy, but they're more likely to stick with it. And if they stick with it, they're more likely to have a good outcome. So I think that's another area of research that we can be looking at. Of course, that's a much longer term kind of research that we would need. It's not just the decision point, but following those patients long term.
Yeah, very exciting. Thank you so much for sharing this data with us.
My pleasure, and we look forward to trying to get the patient's voice out there, and for clinicians like yourself to understand what's important to the patients, how patients are weighing all this information, and how they make decisions about what's important to them in therapies. I don't think doctors or other healthcare providers can assume that they understand what's important to the patient unless we really ask them.
Yeah, thank you.
Thank you, Dr. Daniloff, for all you're doing.